sir.
Visible?
Yes, sir.
Yes, sir.
Now, before we start the class, I want to know how many of you have attended a cardiac OT and had the opportunity to witness a cardiac surgery.
Yes, sir. Yes,
All
sir.
of you had the
Yes, sir.
exposure.
Yes, sir.
But
Yes,
Shiva Shankari said she is little confused because of not having proper exposure. And I am little apprehensive because I am presenting this topic in front of a veteran in cardiac anesthesia, Dr. Kamaji, who has been working in Railway Hospital cardiac OT for the last 15 to 20 years. So anyway, I will try to do my maximum effort to justify. So what is the purpose of cardiopulmonary bypass? It is to provide a bloodless field for cardiac surgery. Why do we require a bloodless field for cardiac surgery?
for operating on heart.
Pardon?
We are handling
For operating on vascular structures.
We have to identify the structures properly and then defective portions to be replaced or corrected. So if the blood is constantly flowing through that heart, you cannot identify the structures and do a repair. So you want to divert the blood flow from the heart and keep the heart still so that you can do the repair correctly in cardiopulmonary bypass. That is the reason why we have that. Now, it incorporates extracorporeal circuit to provide physiological support in which venous blood is drained into a reservoir. Then given added oxygen is added to that to oxygenate that, and then it is pumped back by using some pump into the aorta for supply to all the areas other than the heart. Okay? So the action of heart and lung is replaced by the extracorporeal circuit which is used in cardiopulmonary bypass, and that is why it is called cardiopulmonary bypass surgery. Okay. So to understand this, you should know the components of cardiopulmonary bypass circuit, including cardioplegia system, and the details of conduct of cardiopulmonary bypass and anesthetic considerations. Okay. Now, what is the CPB circuit? What are the components of CPB circuit?
Pump,
Those of you who have attended,
oxygenator, heat exchanger,
Pump,
reservoir,
oxygenator.
cardioplegic system,
venous
filters and tubing.
Very good. So to remember that, if you remember the steps of the surgery, in cardiac surgery, open heart surgeries, then you will be able to give them in an orderly fashion. So once the patient is anesthetized, they open the chest by a sternotomy, midline sternotomy mostly. Nowadays, of course, you have that minimally invasive surgeries, which I am not going to talk about. So it is mainly about the mid sternotomy with the opening the chest and then reflecting the pericardium, exposing the heart. So the first thing the surgeons do is try to drain the blood away from the heart. Okay. So for that, what is the first thing that they have to do, or anesthetist has to help? Huh?
First venous blood we have
Venous
to send.
Venous
First
cannula.
venous. It's the first venous cannula is put. Huh? Before putting the cannula, what should be done? If you drain the blood in directly into a cannula, will it circulate or it will coagulate?
First priming.
Timing is for the machine, the circuit. Correct. You have to anticoagulate. Okay, I will just go through that. So the components of the circuit, these are the aortic and venous cannulae, which are connected to tubing. From the tubing, it goes to a reservoir, and from the reservoir, it is pumped to the heat exchanger and oxygenator for improving the temperature as well as the oxygenation. Then it is pumped into the arterial line after filtration and pushed back into the aorta. Okay, so this is the complete circuit. Drainage with the cannula through tubing into a reservoir. Two pumps, it is pushed into heat exchanger and oxygenator, and then through an arterial line filtered and sent back into the aorta. So the main CPV machine have systems for monitoring the pressure, temperature, oxygen saturation, hemoglobin, blood gases, electrolytes, and safety features such as bubble detectors, oxygen sensor, and reservoir level detection alarm. All these things are there in the modern machine. Now this is a very simple diagram which will help you. So through the venous cannula circulation, you drain the blood into the reservoir. Then you pump the blood into the heat exchanger and oxygenator, and through the arterial line, you send it back into the aorta through arterial circulation. Okay, so this is a very, very simple diagram with which you can remember the components of cardiopulmonary bypass. And this is a more elaborate picture where you can see the left side contains the venous blood is drained via the cannula and tubing into the reservoir, where it deoxygenated blood is collected. It is pumped into the heat exchanger and oxygenator, where this is the place where you can add your gases like not only oxygen but also your volatile anesthetic agents and other things to keep the patient under anesthesia all the time. And then once it is adequately heated, it is pushed back into the aorta through the another pump by the arterial line. So you can see the coloring also. Deoxygenated blood is drained. Then at the oxygenated level, it is oxygenated, converted into what is the lung is doing is done by the oxygenator. And these pumps are the main mechanisms where they push the blood back to the aorta to supply to the systemic organs. Okay, so this is the picture of the whole bypass machine. So remember these two pictures. Now, what is the purpose of the cannula? What are the features and their use? What do these cannulae do?
Patient to the
It will
circuit.
drain the blood.
It drains the blood from the patient to the bypass
Circuit.
machine. Okay, that is the cannula. So you have a arterial cannula and a venous cannula. What are the sizes of those cannula? Which one is bigger, venous or arterial?
Venous.
Very good. What is the size?
Size.
And where are they inserted?
Yes.
Drain
Either
the
SVC
venous
Venous
or
blood.
cannula, there is a two-stage, single stage and dual stage.
Okay,
Inserted at the SVC and IVC, they're joined by YPs.
very good. So it can be cannula
In single
connect the
stage
patient
and
to the CPB machine. That is, patient's blood is drained through them to the CPB machine. They are made of polyvinyl chloride with a wire reinforced, just like your flexometallic tube. They have a wire reinforcement to prevent obstruction or crinking. Okay, and the venous cannula is larger, which is about 12 millimeter diameter, and the cannula can be a single stage or a dual stage cannula. In single stage, it is used mostly for open heart surgeries where two cannula are inserted into superior and inferior vena cava joined by YPs. Whereas in a dual stage cannula, they are used mostly for closed heart procedure where a single cannula is inserted into the right atria. So this is the picture to show that you can see this is the bicaval cannulation or the single stage cannulation where an SVC and an RVC, IVC are drained through two tubes and then connected to a single YPs. Whereas it's a single stage canal, you have only one going to the IVC. And the drainage occurs passively by gravity, relying on the difference between the height of the patient in the table and to the reservoir. Sometimes you can apply vacuum to the reservoir and allow the use of smaller cannula and tubing and decreasing the circuit volume. So instead of half an inch, you can use a smaller diameter tube. So what is the size of an arterial cannula? Venous is 12 millimeter. You said arterial is smaller. So what is the
6 to
size
8.
of an arterial? 8 millimeter, correct. So alternate site for venous cannulation instead of IVC and SVC can be femoral, which is usually done only in cases for minimally invasive or redo surgeries, okay? Not for the regular first time open heart surgeries. So a vent is required to drain the left side of the heart for blood draining through bronchial and Tebesian veins. So this is a additional drainage that is required. Coming to the arterial cannula, it is about 8 mm in size and it is inserted into the ascending aorta. The alternate site for that again is femoral, innominate or axillary, and they are used in cases of emergency or again in minimally invasive surgeries to achieve regional perfusion in procedures that involve ascending aorta or the arch of the aorta. So the three indications for arterial cannulation other than the ascending aorta are emergency surgery or minimally invasive surgery or aortic surgeries. Okay? These are the three conditions where you can use it in other sites. And this picture shows you where the arterial cannulation is done. So this is the ascending aorta. This becomes the arch of aorta. So just at the junction where it ends from ascending to arch, beyond the cross clamp, you have to insert this arterial cannula. And venous cannula is done either through IVC and SVC or on IVC alone. And then it goes to the reservoir, pumped to the oxygenator, filtered and comes back. So this is another simple diagram to make you remember that. So what is the role of reservoir in CPB? They collect the blood drain from the heart. So venous drainage first comes only to the reservoir. So what are the types of reservoirs they can use? Any idea?
Open reservoirs and closed reservoirs.
Open reservoirs, closed, and then they allow passive removal of entrained venous air along with option for applying vacuum to assist or hasten the drainage. They integrate a separate cardiotomy or a defoaming circuit to process the suction blood. And when they are used, a safe level of blood in the reservoir is maintained to avoid air entry into the arterial circuit. And the other type is closed reservoirs have limited volume capacity but offer a smaller area of blood contact with artificial surfaces. And as all of you know, whenever your blood is drawn from your normal vasculature into an artificial tubing, there is immediately an inflammatory response happening. But luckily, even the surfaces are coated with such a way and we anticoagulate the blood, it doesn't get clotted in the circuit, it continuously runs and we are able to complete the surgery. So the closed reservoir produces less inflammatory activation, better sterility and reduces post-operative transfusion requirements. They, however, require a separate circuit for processing the suction blood. So that is a disadvantage. So you can see this is the picture of a reservoir where you can have a suction to create more faster drainage. And it also has a filter. It has a graded filling levels marking the volume of blood that is being drawn. This is the outlet to go into the pump. And this is a simplified manifold. And this is open groove with a non-suction and a closed groove. So this is how the reservoir works. And this is another live picture of that pump. Now, what are the types and differences of pumps used in the cardiopulmonary bypass?
Roller pump and
Roller pump
centrifugal
and
pump.
centrifugal
Roller and centrifugal pumps. Which one is commonly used?
roller pump.
Roller pumps. Earlier they were using centrifugal pumps. Roller pumps include two roller pumps, rollers positioned in a rotating arm which compress the length of the tubing and produce a forward flow. Centrifugal pumps or impellers or stacked cones within the housing. I'll show you the picture which will give you a better idea. And these cones are rapidly rotated, which causes a negative pressure to cause the suctioning effect at the inlet, so blood will flow into that, and also a positive pressure through the other to propel the blood out. So the A here is the roller pump. You can see this is one roller, this is another roller attached to an arm. So the tubing goes like this surrounding that roller. These rolls rotate. So what happens? The blood flowing here is pushed by this rotation movement. Compression effect is there, and there is a forward flow. You can see the direction of the arrow. Whereas in the centrifugal pumps, it is like a cone which is rotating in between the two cones. So a negative pressure is created. So blood will start flowing. It will go in a propelled manner like this and then go. Whereas here it goes just like a straight line and a curve. Here it goes in a rotation movement, comes out. And these are the differences between these two. Nowadays we use mostly roller pump because it is afterload independent, whereas the earlier centrifugal pumps are afterload dependent. Patient's systemic vascular resistance is very important. And there is no flow meter required for roller pump, whereas you need a flow meter to see how much of blood flows through that. There is an increased blood trauma because the tube is crushed. There will be some amount of trauma to the blood, whereas here the trauma is much less in the centrifugal. And there is no backflow because it is a constant pressure applied in a forward flow fashion. There is no chance for a backflow of the blood to go back, whereas here retrograde flow is possible if the pump stops. And roller pumps are quite cheap, economical, whereas this is costly, and it is for short-term use, whereas centrifugal pumps can be used for a longer duration. And these roller pumps, all of you would have seen, are bulky. It will be a big machine kept on the floor, and circuit disruption from excessive line pressure can happen, and greater risk of air embolism is there here, and priming volume is less in roller pump, whereas here it is more. So these are some of the advantages and disadvantages. What are the functions and types of oxygenator?
Bubble and membrane oxygenator.
Bubble and membrane oxygenator. There are two main types of oxygenators, bubble and membrane. Which one is more commonly used nowadays?
Membrane oxygenator.
Membrane
oxygenator.
Yeah. Hello. சொல்லுமா கிளாஸ்ல இருக்கேன். அப்புறம் பேசுறியா? அர்ஜென்ட் ஒண்ணு இல்லையா? So membrane oxygenators consist of hollow micropore polypropylene fibers, which are 100 to 200 microns, and blood flows outside these fibers and gases pass inside the fiber, thus separating, just like your dialysis machine where you have the dialyzer. There's blood flows in one direction and gases flow in the other, and then the whole thing is taken place. And there is less propensity for air embolism, greater accuracy in blood gas control, and there are newer designs which integrate filter to manage emboli. Okay? And the heat exchanger is integrated with oxygenator and placed proximal to it to reduce the release of gaseous emboli due to alteration in temperature. And bubble oxygenators are now not commonly used because of causing more trauma. Hemolysis is more with bubble oxygenator, so almost it has become obsolete now. And this picture gives you an idea. So blood inlet, so it more or less looks like your kidney dialysis filter only. So blood enters here, and there is a gas manifold. These are all the hollow fibers, and the blood flows through that, and this is the gas inlet, and so the oxygen is delivered through that, and it is picked up by the hemoglobin, and this is the outlet for that. And this is the live picture of such a oxygenator. Okay, so this is how the whole thing is live seen. This is a cut diagram to show you how it works. Now from the cannula, the blood is drained with the tubings. So these tubings are also made up of PVC, and PVC has a durability and acceptable hemolysis rate. Even though some hemolysis will occur, it is not enormously high. And plasticizers like diethyl phthalate, which are added to impart flexibility, are potentially toxic. So the flexibility, they add this phthalate, which is a chemical which can show or leach from the tubing, that they can get detached and mix with the blood. And so they are now trying to improve that with another plasticizer called dioctyl adipate, which is less leaching and are under investigation. Now, what is the cardioplegia system? What is it important? This is a short note question repeatedly asked in your theory papers. So you should know something about it. What does the cardioplegia do?
Temporary arrest the heart.
Protection. cause
Myocardial protection, and also it helps in the diastolic arrest of the heart, because the heart will have the inherent ability to keep on beating until you cause the arrest by altering the potassium levels and the fluid. So for intracardiac repair, cross clamping of the aorta is necessary, which will render the heart ischemic. Okay? So to protect the heart, the method of myocardial protection, the heart is perfused with a solution with an electromechanical arrest, which reduces myocardial oxygen consumption. So the purpose of cardioplegia is twofold. One is it offers myocardial protection when there is no coronary blood flow. Second is it also helps in the diastolic arrest to stop the heart beating and become standstill. Now cardioplegia cannula are inserted either proximally through the aortic route or through the retrograde. So there are two methods of cardioplegia, antegrade and retrograde. So separate pumps deliver cardioplegia either antegrade into the aortic grade or retrograde into the coronary sinus, or both can be used in some cases where you require more protection. And retrograde cardioplegia alone results in inadequate right ventricle protection. So that is the reason why sometimes we have to give cardioplegia through both the antegrade and retrograde. And the solution can be a crystalloid or a blood-based solution, and it can be given continuously or intermittently. So the classification of cardioplegia can be antegrade or retrograde based on the route of administration. Based on the composition, it can be crystalloid or blood-based. Based on the technique of infusion, it can be continuous or intermittent. Okay, so three ways of classifying, and most of them are potassium-based solutions. And blood cardioplegia can be, it's a combination of oxygenated blood and crystalloid, which may range from 1:1 to 8:1, whichever. Mostly the pediatric cases, they use more of blood cardioplegia than crystalloid or fluid cardioplegia. And other substances which may be added to that are bicarbonate, mannitol, magnesium, calcium, adenosine, propane, glucose, glutamate, etc. And this picture tells you, see, this heart aorta has been cross-clamped with a clamper. This is the aortic cannula to pump the oxygenated blood into the circulation, and proximal to or at the aortic root, origin of the aorta, you have the cannula, antegrade cardiopulmonary cannula, and the aortic root vent. So this is the way it is inserted into that. And the retrograde cannula can be directly going into the opening of the coronaries and supply to the entire heart. The other circuit components are the gas line and blender, which delivers fresh gas to the oxygenator in a controlled manner. This is what I told you, through which you can give the volatile anesthetic agents to maintain the anesthetic state. And the FiO2 determines the PaO2, while the total flow determines the PaCO2 on the bypass. So arterial line filter is presented distal to the pump and removes particulate matter which are more than 20 to 40 micron in size, so that they don't form a emboli and clot the minor vessels. Now coming to the conduct of CPB, what is the first step you have to do is what is called the
Sir,
priming
excuse me,
the
sir.
CPB circuit. So by
Sorry to
priming,
interrupt,
what do you achieve?
Excuse me, sir.
Ah,
Sorry to interrupt, sir. I'm on duty today, sir. Neuro case, emergency case
you
has
can
come,
go,
sir.
no, not tell me. You can just leave.
Okay,
Please
okay.
go.
Thank you,
It
sir.
is more
Thank
important.
you, sir. Okay, sir.
What is the aim of priming?
To decrease that airless.
Complete, not decrease. Remove the air in the circuit. Okay? So it is called de-airing. The CPB machine is done by priming solution, which is a mixture of crystalloids or blood. And priming with the crystalloid will cause hemodilution, which also improves flow during hypothermia. Heparin, usually 3 to 4 units per ml of the priming fluid is added to the prime, okay, so that it will also help in anticoagulation. Of course, we will be giving systemic heparin before we cannulate the patient, before we go on to the bypass machine. The details I will tell you now. And depending on the pre-bypass hemoglobin, the priming volume of additional external blood may be required to get a target hemoglobin of 21 to 24% in adults or 28 to 30% in children. Okay. Now, what is total circulating volume? You must know a few things about priming, how much to prime, how to prime, what will happen, what is the idea of priming. First point we knew this, if we want to remove the air in the circuit completely, so even before the patient is connected to that, we keep the tubings and the pump and the reservoir, everything filled with a particular volume of this priming fluid, so that there is no air mixing with the patient's blood. But how to calculate the total circulating volume when you are going to use the prime? So the formula that you can use is total circulating volume will be patient's blood volume plus the priming volume. So normally for an adult, what is the patient's blood volume?
5 liters, sir.
5
75 ml
liters.
per kg.
75 ml per kg or 5 liters. So to that we have to add whatever priming volume that we are going to add. That will give the total circulating volume. Okay, that is the first formula that you have to know. Now, second is to calculate the target hemoglobin when the patient is on CPB. How to calculate the target, hematocrit. So for that, the target hematocrit is equal to patient's blood volume multiplied by the hematocrit value divided, that is already patient's hematocrit we could have calculated, and divide that by the total circulating volume. Then you will get the target hematocrit value on CPB. So patient's blood volume, supposing you take this as 5 liters per minute, the total 5 liters, and the hemoglobin is say hematocrit is 30%. He has a hemoglobin of 10 grams. Then it will be hematocrit will be 30. You divide that by the total patient's blood volume, which is calculated by the total circulating volume, which is calculated by this first formula. Then you can achieve the target hemoglobin, which should be between 21 to 24%. So normal hematocrit is 30%. We should have at least 21 to 24 when the patient is on bypass. And calculate the blood required to prime can be used this formula, where target HT divided by the total circulating volume minus patient hematocrit multiplied by patient blood volume divided by the blood that you are going to add, that is going to contribute to the hematocrit. So you divide that using as a denominator, then you can calculate the blood required on the prime. So now what is normal value of cardiac index? How does it change in hypothermia? How is it used in cardiopulmonary bypass?
Normal value
What
of
is
cardiac index.
2.4 to
2.4 to 3.4.
You.
like 2.
Yeah.
Cardiac output by body surface area, sir. So 3.4 to 4.
2.1, sir.
It is 2.2 to 2.4, 3.1. Okay. So the cardiac index normally for a 70 kg adult with a normal metabolism at 37 degree is 2.2 to 2.4 liter per square meter per minute. Okay, that is the way it has to be expressed. And for each 1 degree decrease in the temperature, the cardiac output reduces by 7%. So the pump flow can be reduced by an equivalent factor. That is the importance why we have to know the cardiac index of the patient. So how to calculate the body surface area? What is the formula that you use? So for that, what are the parameters you need to calculate the body surface area? You need the height of the patient and weight of the patient.
Yes, sir.
Yes, you need both. Okay. Body surface area expressed as meter square or square meter is square root of height in centimeter multiplied by weight in kilograms, both divided by 3600. Okay. So first you do this calculation, height in centimeters multiplied by weight in kilogram, divide that by 3600. Whatever value you get, you make a square root of that. Then you get the BSA. So for pump flow to calculate using this BSA and cardiac index is pump flow is equal to body surface area into cardiac index. Okay, so that is the importance of knowing all these formula for deciding how much pump flow rate should be set at using the roller pumps. Now the second step, so these are the first step, priming the cardiopulmonary circuit, deciding what should be the hematocrit, deciding how much pump flow per minute should happen. All these things are all, of course, because the perfusionist is there, we normally don't take too much interest in that, and they calculate, and usually they will have a board where they will write all these things and keep it calculated ready before you start the case. So if you go and sit with the perfusionist, you can learn a lot of things. Now the second step is initiation of CPB. So for that, you give 3000 units per kg of IV heparin. It is administered before arterial cannulation with a target activated clotting time of which will be measured in within 3 minutes to more than 480 seconds. So that is the first step, heparinization. And during arterial cannulation, systolic blood pressure should be between 90 to 100 to reduce the risk of dissection. And the aortic cannulation is done first to provide volume resuscitation in case of hypotension associated with venous cannulation. Okay. So please remember that we don't, Kamachi, am I right? Venous cannulation is not done first. Is it right, or you do that first? It is not there. Okay. So aortic
Yes, sir.
cannulation.
Aortic cannulation is done first. If there is any chance of massive bleeding, we will be able to conserve the blood loss and reuse it again because it's heparinated blood.
So this is the important point. So some of you said venous cannulation first. That is not the correct answer. So I'm also right in saying that. Please remember that.
While coming out also, sir, while coming out
Hmm.
also, they will remove all the other cannula.
Keep the
And
aortic
cannula will be
last.
aortic cannula will be retained even up to 70% of protamine is in.
Okay,
And whatever
okay.
pump blood is there in the reservoir, that will be given back. And once 80% of protamine is in, then they will finally remove the aortic cannula, sir.
Aortic cannula. And so aortic cannula is connected to the tubing. Line pressure is checked to rule out dissection. So this is the first step in the initiation. So first is heparinization, anticoagulation. Wait for the ACT to come to the required level. Then do the aortic cannulation first. Then check the line pressure, rule out dissection. After that, you do the venous cannulation, and venous clamp should be released gradually to establish full CPB. And once your blood is drained fully from the left side of the heart, you can stop the ventilation also. Okay? So how is anticoagulation assessed? How is it affected? How often it should be monitored? These are the questions that you should know. So activated clotting time is the point of care test and assesses the adequacy of heparinization. Normal ACT ranges from 80 to 120 seconds, can be affected by hemodilution and hypothermia. It must be monitored every 30 to 40 minutes during bypass. And if the values fall below 480, then you have to give another 500 units of heparin again to maintain it at the desired level. And ACT can be greater than 300 for safe cannulation. Okay, so all the time you need not wait for 480, and 400 is safe for going on bypass also. And ACT greater than 480 is definitely required for deep hypothermic cardiac arrest cases. And if heparin resistance is suspected, sometimes the heparin may not act, very rarely it may not have the desired effect. Then you have to suspect antithrombin 3 deficiency, and that situation, after discussing with the surgeon, if the total dose of 600 units of heparin per kg does not result in a raise or increasing the ACT more than 480, you can think of giving recombinant antithrombin concentrate for the achievement of anticoagulation. Otherwise, you can also give fresh frozen plasma which may contain antithrombin 3 to achieve this anticoagulation. These are some of the exceptional situations where anticoagulation may not be achieved. Now, coming to anesthesia for unmonitoring in CPB, the perfusion pressure is used as a surrogate marker of organ perfusion, and it should be maintained at 70 millimeters of mercury. Hypertensive patients, those who are at the risk of stroke, require higher flows and perfusion pressures to maintain organ perfusion. Cerebral oximetry, evoke potential, and transcranial Doppler, they are all used to assess the adequacy of cerebral blood flow. And the mixed venous oxygen saturation monitoring provide an estimate of balance between global oxygen delivery and demand. And mixed venous oximetry of 70% or greater is maintained to make sure that cells get adequate oxygenation. And blood level in the reservoir should be monitored to prevent any air embolism. CVP should be low in all these patients because we are not maintaining a normal venous blood flow. And high CVP indicates a poor venous return to the patient. And monitoring aortic line pressure, blood temperature, and integrity of gas supply to the oximeter are very essential. And glucose level should be maintained between 120 and 180 in all patients, especially in diabetic. And anesthesia can be maintained by inhalation route, or total intravenous anesthesia can be given through this pump itself. And volatile anesthetic have the advantage of cardioprotective effect through preconditioning. Nitrous oxide should be avoided because it can increase the size of emboli if there is an air embolism. Anesthetic requirements are reduced when the patient is in hypothermic state, so you have to be very careful in administering the dosage. And drug pharmacokinetics also are altered because of hemodilution and altered metabolism. And temperature management, hypothermia is frequently used in cardiopulmonary bypass, and blood viscosity increases with hypothermia, maintains high perfusion pressure despite hemodilution. But hypothermia has an inhibitory effect on clotting factors and platelets, so bleeding can be more. And core temperature monitoring can be done either through rectum, bladder, esophagus, or pulmonary artery. And nasopharyngeal temperature corresponds to the cerebral temperature. And acid-base management is important during CPB. It's particularly important in hypothermic cardiopulmonary bypass and deep hypothermic circulatory arrest cases. So with the cooling, that is when hypothermia occurs, carbon dioxide becomes more soluble in blood and causes alkalosis by uh, decreasing the partial pressure. So there are two methods of doing the acid-base management. One is called the alpha stat method, which refers to the alpha imidazole ring of the histidine, residue of the hemoglobin, which is an important intracellular buffer. And the constancy of the charge state of this ring is important in regulating the pH-dependent cellular process. And the alpha state pH is not corrected and PaCO2 allowed to fall with hypothermia. This is the major component of this particular technique. So blood gases measured at 37 degrees centigrade are uncorrected. And alpha stat limits microemboli, and maintaining cerebral autoregulation is allowed because the carbon dioxide is not corrected. And in homogeneous cerebral cooling, this is the disadvantage of the alpha stat based management in homogeneous cerebral cooling. Then the other method of acid base balance is what is called pH stat, where you correct the pH according to the temperature. For the correction is done for the amount of hypothermia that is induced. So a constant pH and a PCO2 is maintained by adding PCO2 to the blood sample. So CO2 is added to the oxygenator, causing increased cerebral blood flow and cooling. So prolonged pH stat management, that is, if you go by the pH stat management, can lead to severe acidosis, and so switch to conventional alpha stat during rewarming process is required. So there are schools of thought where they prefer alpha stat all the time and pH stat sometimes. So pH stat as a idea of correcting the deficit of carbon dioxide according to the body temperature, which is not done in alpha stat. That much understanding is enough at this particular stage. And in adults with moderate hypothermia, alpha stat is beneficial. In infants and brain injury, it's more associated with hypoperfusion, so pH stat is useful. So the indications for alpha stat and pH stat are done that. In deep hypothermic cardiac arrest, a crossover strategy can be employed, where you can start with alpha stat, pH stat, and then switch over to alpha stat at the end. This maximizes cerebral cooling and avoids severe acidosis and prolonged pH stat. Now, confirming suitability. After all the surgery and repair has been done, we have to come out of the bypass and make the patient have a normal circulation. So confirming suitability for weaning is, before dismantling the circle, the surgeon must confirm the heart lungs are ready to receive their functions independently. So there are two no's which you have to accept. No conditions include graft failure, valve leakage, or dissection, and there should be no residual air in the heart. So this is the two no's. No condition which causes graft failure, valve leakage, or dissection, and no residual air. Two satisfactory things happen: satisfactory pacing and satisfactory ventilation. These are the two satisfactions that we should get. And two physiological parameters: physiological temperature of 35 to 37, and physiological gases of ABG, potassium, and CO2. And so if these things are satisfactory, then we think of weaning from the cardiopulmonary bypass. So weaning is a process where extracorporeal support is gradually withdrawn as the heart takes over the circulation. This use of hypothermia requires a period of rewarming, and the high gradient between core and peripheral temperature can lead to after drop in temperature. So you must try to get the peripheral temperature and core temperature almost close to each other. Maximum difference can be just 1 degree centigrade. And supplemental doses of anesthetics are administered. Acid-base balance, electrolyte, PaO2, PCO2, sugar, and hematocrit are kept within normal limits as by testing them. And serum potassium 4.5 to 5 millimoles per liter is targeted to prevent arrhythmias. After open heart procedures, de-airing of the heart is done, and for this, esophageal echocardiogram is useful to assess the adequacy of removal of air. And air embolism frequently involving right coronary artery due to its anterior location can cause arrhythmias, ST elevation, myocardial dysfunction. It is treated by increasing the perfusion pressure and maintaining pulsatile perfusion by partially clamping the venous line. And this is Royson's formula for recovery from or weaning from the cardiopulmonary bypass, which is given in Miller. So the mnemonic for that is CVP. The C has 6 components: cold, conduction. That is cold. Patient should be rewarmed to normal temperature. Patient should be in sinus rhythm as far as possible. Calcium should be checked. Cardiac output should be measured. Cells, that is hemoglobin should be normal, and coagulation should get corrected with protamine. For me, you have to see the ventilation, switch off the vaporizer, use volume expanders, and visualize the heartbeat, whether the heart is getting filled up properly and whether it is beating properly. And for the P, you have to see what predictors are there for difficulty in weaning. Give adequate protamine, maintain pressure, use pressors if necessary, use a pacer, direct pacer if necessary, and correct the potassium discrepancies. And this is another mnemonic to remember what are all the things that you have to pre-varicate. So I don't want to go into detail, more or less the same thing will be there. And visualization of the heart is important before termination of CPB, so which you can find out the contractility, distension, residual air presence or conduction, and valvular function all can be visualized by looking at the heart. And predictors and factors contributing to adverse cardiac output, cardiovascular outcome are if the pre-op ejection fraction is very low or diastolic dysfunction is present, the patient already has a renal disease, the female patient and elderly patient, congenital anomalies, emergent surgery, prolonged CPB duration, inadequate surgical repair, all these things are causes for unsatisfactory outcome. Incomplete myocardial preservation during cross-clamping, ECG not asystolic, incomplete diastolic arrest, prolonged ventricular fibrillation before cross-clamping, warm myocardium. The causes of CPB pathophysiology, because these are all the theoretical things: 5 plasma protein activate, 5 cellular causing. These are all the things which cause the problem in CPB. And so 5 plasma proteins, 5 cellular systems, and 5 principal effects in the 5 cardinal systems are the, so the organs affected will be cardiovascular, hematologic, pulmonary, renal, and neurologic. So this is a very useful slide to remember what all the complications it can produce. And these are the pictorial description of what are all the steps that you have to do. First thing you do is induce anesthesia. Usually it is done under general anesthesia, as all of you know. Nowadays they are trying to do it for minimally invasive, other techniques are being used, but normally for open heart procedures under cardiopulmonary bypass, first step is induction of anesthesia. And after induction, we usually put in arterial cannulation. Then central vein line placement is done, and then the patient is handed over to the surgeon. So they make the skin incision and they open the chest. The sternum is given already opened and self-retaining retractors are placed. The sternotomy is done, and after sternotomy, you give heparin to anticoagulate the patient. And the indication that you have adequately anticoagulate is by the value of your ACT. Activated clotting time should be more than 300 to 480 is adequate. And the next step is all the cannulas have been put in. You can see this is the IVC cannula, this is the SVC, this is the aortic. And you can see the size here. The IVC cannula and SVC cannula look bigger, and aortic cannula is looking smaller. This is a case of VSD repair. So all the other, this is the cross clamp which has been applied. These are all the other drains which are there. So blood is now brought into the oxygenator, and these are the roller pumps which are normally used to pump the blood, and this is again sent to the reservoir, and this is the full-fledged view of the cardiopulmonary machine that is being in use. And can you, anyone of you, say what is being done here? Surgeon is holding something like a spoon here. Can you see this picture? Is it clear?
Yes, sir.
Defibrillator.
So he is doing the internal defibrillation. So sometimes, you know, the heart may not start beating on its own. Usually after a good myocardium will start beating on its own when you fill up the blood and stimulate it. Okay? But sometimes it may not start beating well. In that case, the surgeon has to do a defibrillation. So the maximum current that you strength you will use is 40 to 60 joules. These are called the spoon paddles. So they are used to stimulate, and this is the closure of the sternotomy wound. Normally they use the wires to close the wound, and sternotomy closure is done, and the heparinization is reversed with a protamine. So protamine is available in two forms: 50 milligram, 5 ml vial, so 10 milligram per ml, and 250 milligram in 25 is also 10 milligram in ml. So reversal is done, and then patient is decannulated. Okay? So these are the things about cardiopulmonary bypass. Questions or any doubts or any? Kamachi, do you have anything to add to this?
Thing is fully covered, sir. Only thing is when the FFP is available, it can be added to increase ACT when this antithrombin deficiency is happening in the patient. That's
So this is the
nutrition.
basics, and as a BNB students, they will not expect you to answer all the much intricate details like a cardiac anesthetist, but this basic knowledge, I think it should be good enough. If you are planning to become a cardiac anesthetist after your DNB, then you can read in more detail and try to learn more about it. But this basic, I think, should be sufficient for the working knowledge of to function as a cardiac anesthetist. Okay?
Yes. Okay, sir.
And this heparin-induced thrombocytopenia usually manifests with thrombosis, not bleeding. That's,
Yes, sir.
Thrombosis, sir.
yeah.
But will it happen within so short time, Kamachi? Because usually,
Within a,
you know,
yes, sir.
HIT, as I read, is happening usually after 3 days or 4 days. Okay, continuous
days.
heparin therapy.
Yes, sir. The pre-exposure would have created the antibodies, and subsequent dosing will cause within a day or two.
Okay.
And usually, if there is a possibility, then we have to postpone the surgery, elective surgeries if possible, beyond 90 days. By then, the antibody level will come down. Then chances of this HIT again surfacing will be less.
But you can stop that and go for alternative liquidine.
Oh, yes, sir. Yes. If the surgery cannot be postponed, we can go for bivalirudine. It is also being frequently asked as a short note. Yes, sir. Yes, sir.
And have the talk in concentrated next class along with other topics.
Yes, sir.
Delay we had.
Yes,
Sorry
sir.
for the inconvenience because of the initial technical issues, sir. Sorry to the students also. I hope this problem is sorted out once for all.
So I hope I have done justice to Soundarya's doubts and
So Shankar is.
receive Shankari's doubts. Well, no left. Okay.
Yes, sir. Very helpful.
Yes, sir.
Right.
Yes, sir.
Thank you. Thank you very
Thank
much.
you,
Thank
sir.
you.
Thank you, sir. Thank you very much.
Thank you.
Thank you.
Good night,
Good
sir.
night.
Good night.
Good night.